All right, and welcome everyone. My name is Amy Wood. I'm with the Raymond A. Wood Foundation, and we are excited tonight to talk about ongoing management of craniopharyngioma. And we initially had invited Dr. Lewis Blevins, and he brought a friend. So we're really excited to have both of these experts with us. So I'm going to jump in. And I also want to thank Jorge at Pituitary World News for helping facilitate this evening. And I wanted to go ahead and introduce Dr. Lewis Blevins, who is the director of the California Center for Pituitary Disorders at UCSF and professor of medicine and neurological surgery. He earned his MD from Quillen College of Medicine and completed his residency at the University of Alabama at Birmingham. After a fellowship at Johns Hopkins, he served at Emory and Vanderbilt before joining UCSF in 2007. Dr. Blevins' research focuses on treatments for pituitary disorders and diagnostics for hypercortisolism. He is a celebrated educator and author, having edited medical textbooks and written a travelogue. An accomplished artist, his oil paintings are internationally collected, and also one is in our Art of Surviving, which is currently going on for the month of May. He also plays I had to throw that in, sorry. He also plays Scottish and Northumbrian music, enjoys sailing, and is learning Arabic. So we appreciate you being with us tonight, Dr. Blevins. And we also have Dr. Sandeep Kunwar. Dr. Sandeep Kunwar is a neurosurgeon with special interest in pituitary tumors, including craniopharyngiomas. He uses minimally invasive surgical techniques to treat patients with these disorders. He cares for pediatric patients in collaboration with the pediatric neurosurgery team. Dr. Kunwar earned his medical degree at UCSF, where he also completed an internship and a residency. As a Howard Hughes Medical Institute research scholar, he worked in the laboratory of molecular biology at the National Cancer Institute, and he is currently at UCSF. So thank you both for being with us tonight.
It's a pleasure to be here. Thank you for having us join you with this webinar.
Dr. Blevins, would you like to kick it off?
Yeah, so I recall that you had asked me to speak about the management of craniopharyngioma, in particular with the pituitary function, and I gave a lot of thought to that and felt like we should include Dr. Kunwar with us because of his novel approaches to treatment. My experiences before coming to UCSF about 17 years ago were largely related to dealing with surgeons who saw the craniopharyngioma as the offending tumor. And one of the things that I unfortunately saw were that the surgeons were the offending person, in that the surgical approaches at the time and over the first part of my career were aimed at destroying the tumor, removing it, and often the patients suffered greatly because of the approaches that were taken. And I'm not only talking about children, but also adult patients. And when I started at UCSF and started working with Dr. Kunwar, it's clearly had a totally different approach, one that was much more logical, made a lot more sense as far as morbidity and potential mortality were concerned. And he clearly is one of the best surgeons on the planet, certainly the best in the United States as far as I'm concerned, and can accomplish a great amount of resections, but also has such great intraoperative judgment. He knows when to stop and when not to go too far with the operation. So I felt like it would be nice for the group to hear his perspectives and to understand some of the motivation for how he proceeds to manage these patients surgically. And then while we're doing that along the way this afternoon, I'll also speak about some of the endocrine consequences and treatments as well. Andy?
Great, thanks, Lewis. So maybe what I was going to do is start off with a little bit of a presentation on craniopharyngioma. I think some of this is a repeat, but it may frame out kind of how we perceive, or I perceive, this disease process. I've been dealing with this for about 25, 26 years now, so it's definitely evolved to where things are now, and I think modern day pituitary surgery, with Ed Laws following after his pursuit. I trained with him, but his focus always was, he always said, Sandy, whatever you do what's best for the patient. And that's always has been sort of a lingering thought concept, is we have to do not what's good for me, not what's good for my publications. It's really if this was you or your child or your wife or your son, what would you want done? And that's kind of been the overall perspective, and that's kind of understanding the biology of the disease, understanding the outcomes and the data. Of course, everybody wants to do what they can offer, but the reality is what's best for the patient in the end. So with that said, I'm going to share my slides here a little bit, and hopefully this all works out. Let's do this. So I really have the privilege of working with Louis on a regular basis. Together we run the California Center for Pituitary Disorders. He as a medical director and me as a surgical director, and we're both professors at UCSF. And really the topic is kind of key. It's what's the rational approach for how we manage these tumors. And the rational means it has to make logical sense. And again, the outcome is going to be what's best for the patient. So one thing I will say is there is no one answer. And these are two statements that were made by Harvey Cushing, who's the father of North America neurosurgery. He was the first person to ever do a craniotomy to resect a tumor in the brain back in the late 1800s, early 1900s. And he always defined the craniopharyngiomas as a kaleidoscopic tumor. It had solid components and cystic components, and its management is one of the most baffling problems to neurosurgeons. Even though it's a benign disease, it's complicated because its presentation is complicated and its location is difficult, and the location is critical in regards to the structures around it. And more modern times, Jim Rutka, who is up in Toronto, who is a neurosurgeon who just recently retired, says there's perhaps no other brain tumor that evokes more passion, emotion, and controversy as craniopharyngiomas. And it's always enlightening when we discuss at seminars of the experts. Even the experts don't agree with what the best management of craniopharyngiomas are, because there's so much variability. It's not just one disease. But as you know, it's a benign central nervous tumor, but benign doesn't mean can't cause a lot of damage, unfortunately. And so it just means it's a slow-growing lesion. But benign does mean we have to keep that in perspective. This is something that whatever we do has to be long-term. It can't just be short-term, both in how we control the tumor and what complications we get, or what the relevance of the sequelae of our treatments are. But we know where it comes from. It arises from an area called the Rathke's pouch, and that's how the pituitary gland is made. Part of it comes from our sinuses. Part of it comes from the brain. It's the part that comes from the sinuses called Rathke's pouch that form Rathke's cleft cyst, which is the benign cystic version of these lesions. And sometimes those Rathke pouch cells can then transform and become tumors. And there's really two types of craniopharyngiomas, and I'm going to separate those two out because we're not going to talk about the second type. One is called the adamantomatous, which is the most common type. That what happens in kids. It's a bimodal distribution. It happens in kids, and then we see another peak, not as big, in adults between 50 to 74 years of age. We know a little bit of the genetic mutations about it. The other variant is called a papillary craniopharyngioma. They're more solid tumors. They don't have a cystic component. They're only in adults. We don't see them in kids very often. We know that they now have a BRAF mutation, and the reason why that's key is now there's actually medical therapy that's fairly effective for papillary craniopharyngioma. So the management of papillary craniopharyngiomas have really changed our time now, and will completely change in the next 5 to 10 years as medical therapies take over for the management of these diseases. And when we talk about craniopharyngiomas, this is kind of a zoomed-in view of the pituitary. It's such a critical small area, but it's really the Park Avenue of real estate in New York. This is the sella turcica, the bone, and you've got the pituitary gland, the front of the gland, the anterior lobe, and the posterior lobe. And then the posterior lobe connects up with the pituitary stalk, and this is the area called the median eminence. And then this is the base of the hypothalamus. So this wall right here that you see, the cavity is called the third ventricle, and that wall of the third ventricle is the hypothalamus, one of the most critical parts of the brain that regulate our sense of temperature, our eating, our drinking, regulatory rates of our breathing and our blood pressure. A very critical area. It's the deep part of the brain. Right in front of that, or right above the pituitary gland, of course, the optic chiasm. And of course, that could be affected, causing vision loss, depending if the tumor grows and pushes up along the chiasm, or sometimes these tumors are retrochiasmatic and they follow behind it. But essentially, anywhere along the median eminence and the pituitary stalk, that's where Rathke's pouch is. So the tumors can occur anywhere along this region here. So we have some tumors, if you look on the bottom, this is a side view called a sagittal view. So from the side view here, this is primarily in the pituitary fossa growing out of it. That's called an intracellular or infracellular tumor. There's the supracellular ones that involve the area around the pituitary gland. Again, those are the ones that rise around the stalk itself. Some arise at the bottom of the stalk, some arise in the mid portion of the stalk, and then the intraventricular ones arise from the top of the stalk. I call it the infundibular. This area here is called the infundibulum. Infundibular craniopharyngiomas, those are completely in the third ventricle. And of course, one of the unique features of these are that they're cystic. The dark areas here are the cystic portion, the white areas are solid. But they release the cystic fluid is actually an oily substance, kind of very similar to the oil that your skin releases. These are squamous cell tumors. And so when they release this oily material, it causes an inflammatory response, causing these tumors to stick to the surrounding tissues. And so, of course, I can stick to the stalk itself, which is, again, a spaghetti noodle, and any damage to the pituitary stalk will cause devastating damage to the gland itself, but can also stick to the hypothalamus, especially the ones that extend into the ventricles that can then lead to other problems that we try to avoid when we can. In medicine, we always talk about risk-benefit ratios. We always want the benefit to outweigh the risks. So we want the risk to be as minimal as possible. And that's that balancing act that as surgeons we do all the time. We want to maximize treatment outcome, which means very much so if someone has vision loss, we have to make that better. We actually have patients who have hypothalamic dysfunction. We can actually make better. We've had patients who have lost weight after we've decompressed their hypothalamus. We want to get long-term control. I mean, these are tumors. We want to sort of see, can we cure them or at least provide long-term control of them? And of course, we want to maintain hormonal homeostasis of the pituitary gland and the hypothalamic hormones. On the other side that's fighting us is the complications. And because this is a benign tumor, these complications become critical. The other thing is these tumors oftentimes happen in children, which also are critical. Someone who's 85 years old with diabetes insipidus, for example, is very different than a 15-year-old with diabetes insipidus who's going to go to college and binge drink and become an athlete and try to hike mountains, of course. So as a child, since these tumors occur in children more often, we've got to be really focused on what are the cognitive, hypothalamic, and other complications that could arise, including things like hypopituitarism. I think Lewis will mention a little bit later on about the significance of, even though we can replace the hormones, if they're gone, we need to replace them. But if they're working, can we do whatever we can and try to preserve the gland or the function that's there? Some of these patients will present with diabetes insipidus, but many will not. Because these are slow-growing tumors, oftentimes they can be quite large, and even the large ones sometimes can have normal hormonal function. Maybe one or two hormones are up and not all the hormones are out, and oftentimes will present without diabetes insipidus. And if they come without diabetes insipidus, can we treat this tumor and not cause diabetes insipidus, which would be a complication? And then there's issues of surgery with spinal fluid leak and even arterial injuries. Not only do they stick to the hypothalamus, they can stick to the carotid arteries or the small vessels at the base of the brain, and there are many of those. There are no good medical therapies for adenomatous craniopharyngiomas. So we typically, there are some being searched out, and there's no question with time, I think that's going to change. There's some anti-inflammatory agents, interferon alpha, that have been used, but still surgery becomes a primary treatment for these tumors. I will say one other option is always observation, especially in adults. We've got several patients who have these tumors that are diagnosed that we know are craniopharyngiomas based on the imaging studies, but their hormones are intact, they don't have diabetes insipidus, they have no vision loss. We watch those patients. It's perfectly safe and okay to observe a patient if they're not symptomatic, but observe them closely. But if they are symptomatic, one of the advantages of surgery is that we can actually decompress them. So the advantages are we can get tissue diagnosis, prove that this is a craniopharyngioma. We can decompress the optic nerve in the hypothalamus. We can potentially cure them in certain situations if we can get it all out. So when we talk about surgery, one of the key things that we always talk about in surgical decision making is, do we want to try to take the whole tumor out, or do we want to debulk the tumor? Meaning stay inside the capsule. There's a wall to these tumors, and if we stay inside the capsule, we can still remove sometimes anywhere from 80 to 95% of the tumor, maybe 99% of the tumor, but not have to deal with some of the complications which are associated with the capsule. I always tell my residents about 90% of all complications occur in the last 10% of the operation. Because we take out the stuff that can come out easily, the optic nerves are decompressed, the hypothalamus is decompressed, and then we sit there trying to peel tissue paper off of the arteries, off the optic nerves, or off the hypothalamus, and that's where complications can occur. And the question is that necessary nowadays? And there's different surgeries we do. Nowadays, pretty much the standard approach for these have been the extended endonasal transfemoral approach, which is coming through the nose. The complication rates are lower, the recovery is much better. but there are some certain cases where craniotomy is still necessary, and that really depends on the location of the tumor and the anatomy, and of course the experience of the surgeon. And there's different craniotomies or transcranial approaches we use. The problem with surgery, there are always risks, and the risks we want to minimize. And the risks of hypopituitarism can be as high as 85 to 95%, especially if we're going after gross total resection. If we're trying to take this off, you can imagine sort of resecting a blob of jello off of a tissue paper, and that's what it is when we're trying to take these tumors off the pituitary stalk. If the hormones are functioning, oftentimes there will be some degree of hormonal loss, and sometimes there may be even all hormonal loss. Diabetes insipidus is very common, especially if we go with gross total resection, because any pulling or tugging on the stalk will cause dysfunction of the hypothalamic neurons that produce the hormone ADH. The biggest issue is the hypothalamic injury that occurs, and not that it's a fatal injury, although it can lead to long-term morbidity. It's a quality of life issue, and quality of life, especially in tumors where people are going to live 20, 30, 40, 50 years, is a big impact we have to consider. That again, in older patients, maybe not so much of it's always important, but even more important or dramatic in younger patients. And that includes things like hypothalamic obesity, cognitive decline, personality changes all occur if these tumors are involved with the hypothalamus. And of course, with surgery, there's spinal fluid leaks, which we can control nowadays and minimize. And there are still reported cases of stroke and death, and in one very large series of adult craniopharyngioma resections, the rate of death was 5%, which again, for a benign tumor, is that necessary? Is that what's best for the patient? Radiation therapy has always been used, and I will say even radiation, it's just like surgery has improved, radiation therapy has improved. And we've got different modalities. We have stereotactic radiosurgery, which is very, very focused, oftentimes sub-millimeter or 1 millimeter accuracy of delivering the radiation therapy. If it can give in as a single fraction, things like such as gamma knife, and given in 5 fraction, such as TrueBeam, Icon, CyberKnife. There's a whole bunch of different machines now that can do this. It's become so commonplace. Proton beam therapy has been used. The next version is called intensity modulated radiation therapy, which again is still focused. It's focused by about a few millimeters. And so that by then we can, using these modalities, we can eliminate the long-term risks of secondary tumors forming, cognitive decline from radiating the hypothalamus and or the areas called the hippocampus. Standard external beam radiation therapy can still be used for these really large complex tumors that could be stuck to multiple different areas, although it's very unlikely. And there are some intracystic, we can actually give sometimes chemotherapy or radiation therapy directly into the cyst of these lesions. One advantage is that with radiation therapy, it is a definitive procedure, meaning in most cases with radiation therapy, depending on what type you give, the cure rates could be as high as 90 to 95%. And that's cure. That means these tumors don't recur afterwards for a very long time. It does have risks, but the risks are not immediate. Unlike surgery, which, for example, one of the biggest risks of radiation therapy is hypopituitarism. It's about 80%, but it's delayed. With surgery, we cause hypopituitarism when the patient wakes up. We cause diabetes when the patient wakes up. With radiation therapy, that's delayed, and that delay could be anywhere from 5 to 10 years. So typically that 80% risk is about at 10 years, which has a big impact. If you're taking a child or a young adult who's 20 years old, and rather than causing hypopituitarism right away, if we can delay that by either offering a repeat surgery later on if the tumor comes back, or maybe doing the radiation therapy 5 or 8 years later or 10 years later, then they're 30 years old. Now we give radiation therapy. They'll be 40 years old before they develop their apparent hypopituitarism. They'll have gone through puberty. They've gone through fertility. Perhaps we can delay the eventual consequences of a definitive therapy. The other key thing with radiation therapy is it does not cause diabetes insipidus, whereas surgery causes DI. If the patient does not have DI, then we really lean more towards radiation therapy to try to avoid diabetes insipidus, which has long-term sequelae. And then the other downside is long-term cognitive defects. And again, this is something that we know of. It doesn't happen right away. It happens 20 to 30 years later. Again, in younger patients, that's something we have to worry about. But that's where these smaller fields, using very focused ways of giving radiation therapy, we can minimize this risk long-term. And radiation therapy has been effective. In some cases, people advocate it as a primary treatment in someone who does not have vision loss. There's a tumor. You can see this is a side view again. The white is the tumor. The cystic area is the darker area. This patient never had surgery, had radiation therapy, and 6 years later, you can see the tumor's gone. This is without and no risk of diabetes insipidus. Yes, they're going to develop some hypopituitarism decades later. They never had vision loss, so that wasn't an issue. But radiation therapy can be quite effective without any of the immediate consequences of surgery potentially. And when you look at complication rates, we know it's kind of linked to how aggressive we want to be with surgery. When we try to do gross total resections, the risk of causing hypopituitarism. This is new hypopituitarism. So these are people who had normal pituitary gland function, and then we did surgery on them. And these are large-scale series. These are not our series, obviously. This is looking at the literature. There's about a 55% chance of causing new hypopituitarism and a 22% chance of causing pan-hypopituitarism with gross total resection alone. Diabetes insipidus, if they didn't have it before, 30% of patients develop it. And 6% of patients develop hypothalamic obesity when a gross total resection is attempted, meaning complete resection of the tumor. This number goes up to 40 to 50% when the third ventricle is involved. This is all craniopharyngiomas, meaning somewhere below the hypothalamus are not going to be affected as much. But if it involves the hypothalamus, the type that goes above the infundibular craniopharyngiomas, that number goes up to 40 to 50%. That doesn't happen with subtotal resections. If we stay within the cavity, we can keep hypopituitarism to about 49%, or in our series is about 20%. Diabetes insipidus is about 5% in our series. It's about 19% in large-scale studies that we looked at. And panhypopituitarism in our series is less than 5%, but 16%. But the key thing is that all the complication rates are lowered if you don't try to take out all the tumor at one time. And if you add radiation therapy to it, there is a complication with radiation therapy, mainly with the loss of the pituitary hormones. But again, that's delayed. This is immediately. This is 10 years later that can develop. The hypothalamic obesity, I think, is a delayed consequence, but for the most part, much, much less than the obesity from that you get, the HO that you get directly after surgery. And the obesity, the hypothalamic obesity we were talking about is really dependent on location of the tumor, and that's why we have to customize treatment depending on what does a tumor look like, where is the tumor located, is it infracellular, supracellular, or infundibular up in the third ventricle, and really the patients who are most impacted are those that are what's called grade 2, which are the ones that are in the third ventricle. So if it's in the third ventricle right off the bat, I would argue very strongly that gross total resection should not be pursued because the risk of hypothalamic obesity is much, much higher. And what's interesting to me is that, even this is a study from the Craniopharyngioma study, which was a German study that went on for 17 years, and they looked at these patients for long-term follow-up. There was 117 childhood craniopharyngiomas that were followed. And in the patients who had a complete resection, the two key things I think I take away from here is even if you take the entire tumor out, that does not mean cure. That even if you take the entire tumor out and have that risk of anywhere from 30 to 50% complication rates, 5% risk of death, that these tumors still recur. They had a 37% recurrence rate in the patients where the tumor was completely removed. The key element here is you have to follow these patients up for a long time. So when I see reports of the entire tumor coming out and no tumor coming back at 3 years, that has no value, because these are, I kind of tell patients it's like a tree. You chop a tree down, it doesn't mean the tree's dead. You have to wait 10 years to see if a new tree blossoms up again, because these are very slow-growing tumors. So you really do need long-term follow-up to be able to see this. But even a complete resection, taking those risks doesn't mean a complete cure. Likewise, if you don't take all the tumor out, we know the tumors are going to come back. So these are patients where the tumors have recurred, not survival, just the tumor came back, and then we can pursue other therapies. But even in incomplete resections, what's interesting is 30% of patients don't come back. So even if you do just a partial resection, decompress the optic nerves, decompress the hypothalamus, and do nothing, there's a 30% chance the tumor may still not come back. This is the study that was published from our group here. This is a retrospective look at all the literature data that's out there. And what we're looking at is the number of times the tumors come back. If you took out the entire tumor, as I said, in this study, which followed patients up to 10 years almost, is that we saw that 50% of tumors come back in the literature. Even with a complete resection, there's still a 50% recurrence rate. And that recurrence rate's about the same if you did a subtotal resection with radiation therapy long-term. This is one of the longest follow-ups that we have. Again, the longer you follow these patients, the better data you get. But this is the key thing here, is that really the outcome, whether you look at whether the tumor comes back or whether the patient has survival curves, which again, these are benign tumors, they should not have a significant impact on survival. There's no significant difference between whether you took the entire tumor out or whether you did a subtotal resection and then gave radiation therapy afterwards. And now we also know that whether you give the radiation therapy right away or you delay the radiation therapy till later so you can document the tumor coming back had no long-term difference. So whether you give surgery, subtotal resection, and then give radiation 3 to 6 months later, or do a subtotal resection, if it's a child or young adult, wait. Give them some time. Let them develop. Let them have their kids if their hormones are still functioning. And then give radiation therapy 5 to 10 years later. As I said, 30% may never come back. And then the long-term outcomes are not different. So again, the goal is to try to preserve function and quality of life as long as we can before we do a more definitive treatment. But as I mentioned before, the risk of a subtotal resection with radiation therapy have much lower complication rates than a gross total resection. So, when we put all these together, there is no one answer, and because the reason why is these are MRI scans of craniopharyngiomas from looking from the side view. It's a T2 weighted image, so we can look at the optic nerves really well. Here we can see a tumor that started in the pituitary gland that grew upwards. It's what we call a monocystic tumor. These are the tumors we actually like to do surgery, and it's pushing the optic nerves. The optic nerves are pushed way up here. We can do surgery. We do a subtotal resection because oftentimes our hormones may still be normal. We can do a subtotal resection and treat this with alcohol or a sclerosing agent. And then if it's a child, we buy them 5 to 7 years, maybe 10 years. And if we have to treat them again, we can to get them through puberty. That's assuming their hormones are working. Now, if the hormones are not working, then this is a tumor that, yes, you can completely resect and potentially cure. Tumors that go in the cella and out of the cella, it all depends on what's their hormone function. If they've already got diabetes insipidus and they've already got panhypopituitarism, then we can be aggressive in these tumors and try to take them out. If their hormones are intact, again, we go back to the subtotal resection and watch them, or subtotal resection and radiation therapy at some point. This is a third ventricular tumor. This is a tumor that if you take it out, they're going to have significant problems. They will definitely be panhypopit. They will definitely have diabetes insipidus, and about a 40 to 50% chance of having hypothalamic damage. Still do it through a transfemoral approach coming from below, and then we can either give them radiation therapy afterwards or giving it delayed. But my point is what the ideal treatment is depends on what the optic nerve is doing. Is it, do they have normal function? Do they have visual compromise? Where the tumor is located? Is it in the cella? Is it above the cella? Is it in the third ventricle? What's the hormonal status? Is it normal? Did they lost all their hormones? Do they have diabetes insipidus? And of course, the age of the patient also has an impact. So we put all these together into a pot and say, okay, what makes the most sense? We have to customize therapies. Like now we customize chemotherapies for cancers based on what are the genetic abnormalities that exist. We can customize it based on what's going on with the patient. There are some patients with these very large tumors that have completely normal hormone functions. Well, in that case, that's going to change how we approach this versus some small tumors where they've lost all their hormones and they have diabetes insipidus already. Well, then we can be very aggressive and take the entire tumor out. But my point is it's a mixed bag of tumor cells. It's not the same tumor in every patient. Some are very simple, some are complex, and some are extremely aggressive. And again, we've got to customize that to the patient itself. So as I mentioned, really it's a mixture of diseases, and that's why it's so debated heavily. Because not only is it sometimes it's a benign tumor, and so we want it with benign tumors. We know if we can take it all out, it's curative. But there's a lot of sequelae to taking it all out based on its location. So really the optimal management is a combination of taking the symptoms, the tumor size, the location, the patient age, the preoperative deficits, meaning hormonal and visual, and then making a treatment plan that makes sense. A lot of this also is dependent on the experience, that no one path fits at all, but really treatment has to be customized to the individual patient. But this does require expertise. We need to be able to operate through a transnodal approach, operate through a transcranial approach. We need to know the anatomy around this. We need to know about the hormonal status of patients and what the long-term sequelae is. We need to know everything there is about radiation therapy. I also do radiation therapy with doing radiosurgeries because that allows me to say, people who do radiation therapy want to give radiation therapy. People who are surgeons want to do surgery. If you do both or do all or have a team that does it all, which is the ideal scenario, then you can really customize it to what makes the most sense. And that really, in these younger patients, the quality of life is a key consideration. It's not just, hey, the MRI scan looks great, my data looks really good, I've got a 90 or whatever, 85% cure rate, but what's the sequelae of what's the patient look like at the end? And that's what we have to take into consideration. And these are like trees. You need long-term follow-up. You don't know if a tree stump is really dead unless you follow it for 10 plus years to sort of prove that, yes, this is taken care of. And then, of course, the hormonal effects, even if they're normal and even if you're able to preserve them, over time they will decay. That's just from age. They need long-term hormonal management as well. And so, as I said, Lewis and I kind of manage our California Center for Pituitary Disorders. I do the surgery side of things, but Lewis really does sort of the hormonal side of things. I think he can comment more about the long-term hormonal follow-up that's necessary for these patients as well.
Well, Sandeep, we have a couple of questions, but let me start by saying that was a tremendous discussion or presentation about the things that lead to your strategic approach. But what would be your advice to a family who has a child has a craniopharyngioma? Maybe they've seen a physician in Akron, Ohio, or some place that doesn't have a pituitary center of excellence, and they have a surgeon who says, I can get it all out. Everybody wants a tumor removed, right? And what words of advice would you give? I would tell them all to come see you in San Francisco.
Well, no.
Not everybody can travel, but what are the cautions? What are the things that people should do if they're presented with a child that has this tumor and they're seeking the best health care for that individual?
Yeah, I think one thing to always keep in, the two things we have to balance out is, one is what's the acuity. If a child presents with hydrocephalus, that has to be treated acutely because that's a buildup of fluid because of craniopharyngioma. These are very large lesions oftentimes and very challenging no matter what. And so one thing to do is resolve any acute deficit. If they've got hydrocephalus, they should get a shunt. A shunt is a very simple procedure, does not eliminate the possibility of doing anything else, more surgery, more radiation. It's a very simple operation that's standard. If they've got sudden vision loss and they're going blind, then I would say at least pop the cyst. We do a lot of cyst drainage in kids where we can actually put a catheter and drain the cyst and at least buy this a time. The tumor itself, craniopharyngiomas, grow very slowly. There is no rush. There is no urgency. If a surgeon says this has to be operated on immediately, then I would say definitely get a second opinion. But the cyst can grow fast, and the cyst can easily be treated by, again, doing a biopsy. The cyst is draining the cyst, does not eliminate any further treatment in the future. So I would say treat the acute process. That has to be treated. We don't want to risk vision loss or if hydrocephalus can cause death. Now that's very rare. In most patients, they have some pituitary loss, some mild vision changes. And in those situations, again, these tumors grow slowly. The cysts grow faster, but even a fast-growing cyst grows over weeks to months. The solid portion of the tumor grows over years. And so you have a window, I would say, is, if you are in a location that doesn't have a multimodal pituitary program, then I would say, get a second opinion. And now the nice thing, one good thing about COVID is that Zoom has become so flexible. And now we consult with patients all throughout the United States and even the world now without them having to, before you have to be rich or have a rich uncle to be able to go travel and get a second opinion. You don't need to do that anymore. Now we can do Zoom meetings anywhere in the U.S. and in the world. And not that you have to travel there to get their surgery, at least you can get a second opinion to say, okay, does this really make sense? And you have to be thinking not just for the short term, you have to plan out the road for the long term. You want to make sure you don't burn any bridges in the future. You want to make sure whatever is still functioning, we can preserve. And you definitely want to be cautious about the surgeons who just do surgery because, again, if you go to a BMW dealership, most likely you're going to walk away with a BMW because that's what they do. And you want to make sure someone says, okay, well, what about radiation therapy? Does that make sense? What about are the hormones managed? Do we have all the hormones? Do we understand what's going on? We need to put everything into the pool to figure out what the best option would be.
So we have a question from Rachel who says, regarding recurrence, when is it most likely to be seen? They've been told between 5 and 10 years on average.
Yeah, it's variable, but that's about right. But the cysts can actually recur earlier than the solid portions can. So that's why we do get MRI scans every 6 months to every 12 months, just to be able to monitor more for cyst recurrence. The solid portion of the tumor, typically, if it's just a subtotal resection or even a gross total resection, typically could be in the 5 to 6 year, 5 to 10 year window. There is some patients we see who don't have recurrences. We had one patient who was 14 years out and still had no recurrence. I don't think she's cured. The goal wasn't, she had completely normal hormones, so we know we did a subtotal resection on her. And then we've had some patients where we take the tumor out and within a year the cyst comes back, and then we have to address that as well.
And Dave says, thanks for the outstanding presentation. Are there any studies on the life expectancy of craniopharyngioma survivors?
Yeah, so we were just talking about this earlier. Life expectancy is dependent on two main factors, really three. I think Amy brought up one other good point is hypothalamic obesity changes not only the quality of life, the pathway of life. And so that's something that we can fix the hormones that the pituitary gland make, but even then we don't do as good of a job as the body does. So again, if we can preserve those hormones, we want to try to preserve them at all costs. And if we can delay, that's one of the things I like about radiation therapy, is we buy another 10 years of time for younger patients. Of course, if you're 7 years old, we give radiation right away. We don't need to wait. But if you're younger, we try to wait and hold off if we can. So I think the overall, though, by the tumor itself, the overall survival is pretty comparable to the general population as long as you don't have hypothalamic obesity, diabetes insipidus, or hypocortisolemia. But the two biggest risk factors for early morbidity or mortality is going to be diabetes insipidus and hypocortisolemia.
So Yara asks, what are your thoughts on radiation when a patient already has had a stroke and some vascular abnormalities? We see that often. We see patients who come to us who have residual disease, who have had tumor aggressively approached, and those small blood vessels are torn. They get perforating vessel tears and end up with strokes and hypothalamic dysfunction and other syndromes as well. So I think it's a relevant question. How would you respond to that? Is radiation safe in those type of patients?
Yeah, the radiation, one of the other concerns we didn't talk about is the increased risk of stroke. We don't talk about that when we talk about stereotactic radiosurgery. We haven't seen that, but with external beam radiation therapy, we know there's about a 0.7% increased risk of stroke over time, and that's over someone's lifetime. So again, for younger patients, has a bigger impact than for older patients. But again, we know what the sequelae of the disease would be. As the disease progresses, that can cause hypothalamic dysfunction, vision loss, and more damage. So we have to weigh those two odds out. Typically, when we do give radiation therapy, and this is one of the other reasons why we do surgery, is if we can narrow the field down. If someone's got a very wide, big tumor or big cystic components, the cysts are easy to treat, but even the solid portions, if we stay within the capsule, we can shrink. Then what happens over time, everything collapses down, and then we're radiating a much smaller field if we have to give radiation therapy. So minimizing the field of radiation with surgery, that can be done safely, is key. The second thing is going to be to use the most focused way of giving the radiation therapy as possible. So ways of stereotactic radiosurgery, even if it's fractionated, or to use what's called IMRT, which is now readily available almost in every major city.
Jason asks, what about people who are 30 years out, MRI recurrence? And I don't know if that's a reference to it being possible or what would you do to that, but maybe you can talk about people who might have a late recurrence.
Yeah, so, 30 years out is pretty good. The question is, are you ever cured? When can we say we don't have to worry about this ever again? And the answer is we don't know, because the treatments have gotten better and better and we don't have follow-up yet. If you're 30 years out and don't have a recurrence, I would still continue to get imaging studies at least every 5 years just to be safe, not only to look for tumor recurrence still, but to look for any side effects of the previous treatment, perhaps. If there is a recurrence at 30 years, it goes back to where is the tumor located. If it's a small recurrence and someone's had prior radiation therapy, we know after 10 years we've regained some of the tolerance of radiation therapy. We could use focused, again, not standard, but focused radiation therapy again. Of course, if it's in an area where it's in the sella, or in an area where if someone already has diabetes insipidus or hypopituitarism, then yes, we can go in and take the whole tumor out, in those situations. So again, that's all based on location and what the current status of the hormones are.
Christina asks, and I can answer this one and probably Kristen's question as well. Christina says, child had radiation only for tumor 16 years ago, no issues, tumor was said to be dead. Now a cyst that has appeared in 3 months, recheck it's a bit larger, no vision or endocrine issues, child is now 26 and can't be treated at St. Children's Hospital, not sure where to turn. My answer would be to get a video visit with Dr. Kunwar and just get an opinion, and he can help you find a surgeon close by if you can't come to this institution. But this is a cyst that you were talking about earlier. It might need to be drained. We'd obviously have to see what it looks like on the scan, but it may be a cyst that will potentially cause trouble later. And Kristen has a fast-growing first resection July 2023 and February 2024, and it's back already. So that's another patient that needs to see a surgeon, get a second opinion, and develop a treatment plan. But it sounds like radiation might be necessary there. And maybe for both of these patients, radiotherapy could work.
Yeah, the radiation therapy is very effective. Immediately it stops the growth of the tumor. Unfortunately, it takes about 3 to 5 years to see the full effects of the cyst. And after 3 to 5 years, we actually will see cyst reduction. But it's not unusual if someone's got a rapidly occurring cyst that we either we treat the cyst and then give radiation therapy to prevent recurrence, or we treat with radiation therapy with the chance that at some point there'll be a delayed response to the cyst. So even though the tumor may not grow, over the next year, the cyst can still grow, and we still go in and we just pop the balloon, which is just treating the cyst. And as I said, in certain situations, we've actually given therapy into the cyst itself to prevent these cysts from coming back rapidly.
So I think everyone on this group probably understands that there are these tumors are adventures, and it's a long-lasting adventure and a long road to travel down. I have one patient who I think has the record number of interventions for craniopharyngioma, and this is a patient that Mike McDermott took care of with me. He's had 12 different surgical procedures, about 3 shunt procedures, and 2 or 3 courses of radiotherapy. Finally, his tumor stopped becoming a problem after all that intervention. So you really have to be willing to stay on top of these things as life moves forward. Jennifer says, what other options to treat recurrence are new, particularly infusions or drugs, if someone has already had both the treatments, radiation, and surgery?
Yeah, I think for papillary craniopharyngiomas, because of the BRAF mutations, we've got some very good therapies now that are available. There's a multitude of BRAF inhibitors now that have shown to have some efficacy. I think for the adenomatous craniopharyngiomas, it still boils down to surgery and radiation therapy. There's people have tried. There are a couple of clinical trials looking at various drugs for craniopharyngiomas, including intracystic P32, which is a radioactive material. Interferon alpha has been used, especially in kids. We've seen a regression of cyst and tumors over time. Unfortunately, many of these are sort of therapies where about 20 to 30% of patients may respond, and we still don't have the predictive values as to which will, which won't. And so that's where the clinical trials become very useful, so we can better understand future treatment options. We understand some of the mutations now in adenomatous craniopharyngiomas. The problem is we don't have any good drugs yet. And so I think, maybe in another decade or so, hopefully as we get more molecularly targeted therapies, that may change like it has for papillary craniopharyngiomas. But even with papillary craniopharyngiomas, the medical therapy doesn't always work. But the good news about those tumors are, one, they're more amenable to surgical resection because they don't release an inflammatory component that causes it to stick to the scar tissue to all the other surrounding tissues. And then 2 is that they're still, papillary craniopharyngiomas are also very sensitive to radiation therapy.
Janet asks a good question. How far out is it safe to reduce the frequency of MRI to more than annually, I suppose?
Yeah, I think, the further you get, the safer it becomes. We typically follow patients if things are stable, for the cystic portion, for kids especially, every 6 months for the first few years. And then we can go to every year for at least about 10 years. And after 10 years, we can back off to every 2 to 3 years. But that's assuming nothing's changing. If anything's changing, even if it's a small change, we go back to that yearly MRI scan. But I think after 10 years, we can definitely back off a little bit. If someone's had radiation therapy, then we back off a little bit sooner because we know that the control rates are so good.
So we have 2 questions about radiation. The first one is, what type of radiation do you feel is best?
Yeah, I think the one that's the most focused and the safest. Because again, like surgery, we can't undo the effects. If we cause diabetes insipidus, we can treat it, but we can't undo it. If we cause hypothalamic damage, we can treat it to some degree, compensate for it, but we can't undo it. Once you've given radiation therapy, you can't undo it. And that includes people who have been gung-ho with trying to give single fractionated radiation therapy near the optic nerves, which is very dangerous, and yet it's been done. And we have had patients who I've seen who've had radiation-induced optic neuritis, which is damage to the optic nerves by radiation. We can't undo that factor. So my feeling would be is, again, it's whatever's the most conformal, and things like gamma knife or cyber knife are very, very conformal, but it also has to be the safest. So sometimes we do go back to IMRT, which is once a day, 5 days a week for 6 weeks. It is a longer course. Gamma knife, cyber knife, true beam are not more effective than IMRT. It's just easier and more focused. But even IMRT is somewhat focused. It's a longer period of time, but it's just as effective in stopping these tumors from growing back.
And Amy says, we were advised not to do radiation for my son's craniopharyngioma because the radiation could cause a malignancy in the future, and then asks, can you discuss your thoughts on this philosophy?
That's completely true, and that's something we've seen is that, there's lots of studies now have looked at long-term sequelae of radiation therapy, and what I will say with the focused radiation therapy for about 1%, and that's on average is 14 years later. So
And
it is something that we have to balance
your,
off. There's always a risk of...
Your video feed interrupted. If you could repeat the answer to that question, that would be great.
Sorry. Yeah, so the question was, the advice against radiation therapy because it can cause secondary tumors to form. And we know that risk is dependent on a few factors. One is the volume of tissue treated, and hence why the more focus we can get, the better. And looking at gamma knife radiosurgery, which we've got a lot of experience, we've had our machine for over almost 30 years now with various versions of it. That's the most focus in my mind. Cannot be done if it's close to the optic nerves, so that's one key limitation. But with that, we know the risk of secondary tumors is less than 1% because we're not treating a lot of normal tissue, we're only treating the damaged tissue. But you also have to realize, the risk of a secondary tumor occurring actually in someone's lifetime for a child is 2% in the brain. So even without any radiation therapy, there's a 2% risk that a secondary tumor can still form. So with external beam radiation therapy, that risk is 4%. So that's the IMRT version, where it's still pretty precise, but there's a 4% risk, which is higher than the 2%, which would be the national. So this is a randomized study looking at not randomized, this is a study looking at 42,000 patients in Europe where they're able to follow them out. And these 42,000 patients who had some form of brain tumor without some form of benign brain tumor without having radiation therapy, the risk for a second brain tumor was 2%. Patients who had radiation therapy, this was about 700 patients with craniopharyngiomas that were radiated, the risk was 4%. And that's with IMRT. So again, the more focus you can give it, the better. The good news of those 4%, only 2 of them were malignant tumors. So most of these are secondary benign tumors. And again, yes, we're treating one benign tumor from another, but in the end, we have to take a look at the risk of causing, stroke or hypothalamic damage or treating the tumor effectively, which is one of the reasons why if we can delay it, I will say our algorithm for Lewis and I work with adults a lot, and some kids, I work a lot with the pediatric group and the kids, is if their hormones are working, we'll even offer surgery every 3 to 5 years because we know the surgery's now become so safe and well tolerated to 2 things. One, avoid a definitive operation that can cause panhypopituitarism, diabetes insipidus, or hypothalamic obesity. And then 2 is to delay radiation therapy if that's going to be the final treatment, to be a definitive treatment as long as we can. And, we have one child who we treated him initially when he was 12 years old. His hormones were functioning. We did a subtotal resection. When he graduated college, we treated him again with the surgery again because the tumor recurred. And his father was very thankful because he actually had normal puberty. He was a collegiate athlete. And then at that time, we did this surgery again. And then we waited another 6 years before we gave him radiation therapy. So the reason why is, again, at 20 years of age, we thought, well, can we get him through fertility? Can we get him to, since his hormones were still normal? And even when we did radiate him at the age of 26, 27, we knew it's going to be another 10 years, 8 to 10 years before he loses his hormones. But then I think we don't have to worry about it as much. It's different when we treat a patient who's maybe 55 or 60 years old, the second peak, that if we do surgery and they're already hypogonadal, then we're less worried because the main risk there is hypothyroidism, and that's a very easy treatment algorithm. So then we'll do surgery. If we can take it out, great. If their hormones are functioning, we want to preserve the stalk, preserve the pituitary gland, then we'll take it out, give them radiation therapy, and then over the next 10 to 15 years, we'll have to watch their hormone levels closely.
I think that answer really highlights the philosophy of the fact that we don't really know if people are ever truly cured of this condition. So you have to sort of strategize so that you can do the least harm to that individual as life proceeds and goes on. Another good question about MRI. Is it okay to eventually stop using gadolinium in patients who are requiring regular MRI studies?
Yeah, so I think, gadolinium has had mixed feelings about it. We know with malignant brain tumors, we give patients with MRIs and gadolinium every 2 months, and we do that for 3-4 years sometimes. The answer is if you want to be very precise and you want to know the earliest the tumor comes back, gadolinium is going to be the best option. If you're okay and you're far enough out where the likelihood of the tumor coming back is lower, we don't have to give gadolinium, but we're not going to be able to detect it when it's a small nodule. It'll oftentimes be much bigger before we see some changes going on. But no, we do that not, I wouldn't say frequently, but we do that in some patients who have kidney failure or have issues related to the contrast material of not giving them contrast, but we're not going to be as sensitive to picking up early recurrence.
Montserrat relates that the son had a craniotomy, and after 30 sessions of proton beam, he has damage in his right eye. Could it improve with therapy once there's already an optic nerve damage?
Yeah, if it's it depends on what the damage is from. Optic nerve, unfortunately, is central nervous tissue. There's peripheral nerves, peripheral nervous tissue, and central nervous tissue. Peripheral nervous tissue are the nerves in our arms and legs, are the nerves that go to the face. They actually can heal. They'll recover from radiation injury or from surgical injury as long as they're not cut. Optic nerve is a central nervous tissue, which means it's brain tissue. So oftentimes, if the damage is compressive, if something's pushing on it, we can improve that. But if there's damage because of surgical damage to the blood supply or damage because of the radiation therapy, sometimes that's permanent. Sometimes with the radiation therapy, we have in the past tried, as I mentioned, we've had patients who've had high dose radiation, even though it was too close to the optic nerves. We've given what's called hyperbaric therapy, high oxygen therapy, which they've used for skin lesions that happen after radiation therapy with skin burns. Same hyperbaric chambers that they use for divers, for example, but increasing the oxygen content may help to improve it, but they're all anecdotal. There's no large-scale study to look at that.
So Elizabeth writes that she had an endonasal subtotal resection July 2023 and a recurrence during photon radiation in September of the same year and a craniotomy a few months later in December 2023, and wonders if there's a way to know if the recurrence was real or a tumor reaction to the radiation.
That definitely happens. There's been publications out there and we've seen it ourselves where when you give radiation therapy, things expand a little bit. The cyst may grow. It's an inflammatory component, and then spontaneously resolves afterwards. But the answer is we don't know. I mean, the solid portion of the tumor should not recur if it's a craniopharyngioma that quickly, but the cystic portion definitely can. So it's either possible. There's no way to really know for sure.
Jessica writes, is IMRT the same as proton beam? So maybe you could talk about proton beam therapy versus the other forms.
Yeah, so proton beam is a type of stereotactic radiosurgery. It's different than IMRT. It has pluses and minuses to it. One, it's not commonplace. Not every place has it. In order to have a proton beam, you have to have a proton beam generator, which means a nuclear reactor. And so now that used to mean a building to be able to generate the proton beams. There's a company now that can manufacture it in what's essentially the size of a big room. But what it can do, it uses a different principle of giving radiation. It uses what's called Bragg's peak and giving protons, which then stop, and so you can get closer to critical tissue. You can also give much higher doses. I think the one thing I would be cautious about with proton beam is you can use it as a sniper bullet, or you can use it as a nuclear bomb essentially, and you have to really sort of pick and choose. Yes, you can give more dose of radiation, but with craniopharyngiomas you do not want to do that. With other tumors like chordomas, we do. So I'm a very big fan of proton beam therapy for chordomas because we can give a much higher dose and give it focally. We can still use it for craniopharyngiomas, but we need to give a lower dose because, again, just because you can give a higher dose doesn't mean you want to, because we have seen patients with hypothalamic damage related to proton beam therapy giving a higher dose. We don't know the dosimetry fully yet. We've got hundreds of thousands of patients who've had radiation therapy to the brain where we know what can be tolerated, what can't be tolerated, especially in the areas of the hypothalamus and the optic nerves. We're starting to get a better feel for that for proton beam therapy. Even though we can give a high dose, the question is what is the safe dose and what's the most effective dose? So that's proton beam therapy, which is different than IMRT. IMRT really is intensity modulated radiation therapy. So it's a way of giving radiation therapy that's focal, but not as focal as stereotactic like proton beam or gamma knife or cyberknife, but it's got about a few millimeter accuracy, so there's a little bit of tissue that gets radiated, but it modulates the radiation therapy. So the way the beams come in can be differed for every angle, so to protect things like the optic nerve, the brain tissue, the hippocampus, and other structures. And now there's hippocampal sparing IMRT. It's all software driven. It's high computational analysis of how to give the radiation therapy without putting any radiation in the areas of the hippocampus, which are next door, which nowadays I think is pretty routine, so you can avoid the long-term cognitive effects. So again, my point is a lot of the radiation therapy data of these secondary tumors, of causing all this damage to the cognition, is based on external beam radiation therapy, where we radiated the tumor plus essentially a 2-inch margin around it, which we don't need to do anymore.
So Dave says he wants to advocate for MRIs as frequently as insurance will allow, and relates that his tumor recurred after 28 years, at which time he was no longer getting regular scans. I think that's an important point. You should always get scans. The interval, whether you skip 2 or 3 years between, depends on the prior years, I suppose. We're almost top of the hour. Just a couple more things. Yara says, what's the best way to get an appointment with you for non-USA residents? And I think that would be the same for USA residents as well. And we're pretty friendly, and it's pretty easy to get you set up. The easiest way is to write either Sandeep or myself an email. Our emails are easy. It's our first name, Lewis.Blevins, and Sandeep.Kunwar@ucsf.edu. And if you write us, we'll forward that to the appropriate assistant who works with us to schedule consultations, and we can get that set up for you. Kristen asks, what are your thoughts on T3, T4 therapy? I'll address that quickly. So some patients require T3 in addition to T4. Usually we start with T4, and if we can maintain normal T4 and T3 levels on therapy with T4 alone, that's preferred. We will add T3 in patients who have low T3 levels, or sometimes if they have depression as well, we'll add T3 as well. It's probably about 15% of our practice take T4 and T3, just because most people do fine on T4 with the liver and the kidneys making the conversion as necessary. High-dose steroids and beta blockers can delay that conversion, and those patients are the ones who more likely require T3 therapy. And I wanted to get back to an earlier question I thought might be a good one to sort of wrap up with. Let me find it here. Again, another one from Tara. Thank you for this very informative presentation and for your work in the field of a rare tumor. Is there any recommendation of what we as a tumor community can do to advocate for more monies to be designed for more studies on craniopharyngiomas?
Yeah, I think I'd have two questions. I mean, it is a rare tumor, and unfortunately a very complicated tumor, as now hopefully everyone understands. That's why there hasn't been one answer to every patient. It really has to be customized, and I think multimodal therapy, having a team approach, is critical. I think getting resources is always challenging. Actually, I would sort of ask Amy this question, because I know she's been fighting this question and looking into all these options herself.
So I was getting your email addresses and I missed the question. So,
what can the organization, what can we do? What can we all do to sort of partner to get more monies for research and investigation and treatment for patients who are and families who are affected by this condition?
Well, I'm glad you asked, because actually today we just launched the hypothalamic pituitary brain tumors and craniopharyngioma patient registry. So we do invite everyone, patients and caregivers, to register, and I'll provide the link in the chat. And we have an initial set of surveys. So a registry basically captures some data to help us kind of pave the way to advance research and improve treatments. And that's both considering the diagnosis and treatment of craniopharyngioma, but also the long-term challenges that patients face, because we need help on either end. So that is one way to definitely help us help you, because we are working really hard to advocate for research in this area, and to fill those gaps in research that we so desperately need, and to determine the patient's priorities. So what are our priorities in research? What do we need to know more about, whether it's sleep issues or behavioral issues or obesity issues? Those are all things that we are going to start really digging into, but we need your help in the patient registry. So I'll put that link there.
All right, the last comment I'll have is just a public service announcement. For those of you who have hypopituitarism and steroid deficiency and have to take glucocorticoid hormone replacement, or if you have a family member who has to do so, don't ever stop the medication unless a pituitary endocrinologist suggests that you do so. under no circumstances should you stop that medicine unless your endocrinologist says we need to hold it for this or that for whatever length of time. That's all I have to say. Sandeep, any concluding thoughts?
No, I mean, I commend, both Robert Wood Johnson Foundation with Amy and with Lewis and the Pituitary World Network with Jorge as well for bringing out some more information. And knowledge is key, it's power, right? And this is where, in the world of the goods of social media is that we can get access to these podcasts and to more information. So I think this is, I commend both to sort of building the format and the basis and the infrastructure to be able to get this information out there. And I think the registry is going to be very, very important because data, everyone's got their own little sets of data. And unfortunately, as a surgeon, I realize this very well, and we know it internally, is that we can make our data say anything we want to make it. But you have to look at large-scale data and long-term follow-ups to really make it sort of applicable and really put together some algorithms. And hopefully, I think that's one of the things we're working on is can we put together an algorithm where we put all these information in to help the people who don't have the same experience, and so they're not reading one paper or two papers and making their basis, the recommendations based on that.
Great, thank you. It was such a pleasure to collaborate with you all and the Pituitary World News and Jorge, who's been behind the scenes. Thank you for going into this deep dive on the treatments. I think it was really beneficial and informative. And even 9 years into this, I've learned some new things. So, and Dr. Blevins, thank you so much for coordinating this. We really appreciate it. And hopefully we can do it again, because I'm sure there's a lot more information we could tackle outside of an hour. So again, thank you all so much for attending. The email addresses are in the chat if I give you a few minutes to grab that, as well as our link to the patient registry, which we really encourage you to join. So thank you all, and have a lovely evening.
Thank you. Good night, everyone.
Thank you.
Good night.
Bye.